Africa and also Sub-Saharan Africa. And this is really supported by the Gastro Foundation of South Africa, as well as the Project ECHO at the University of New Mexico in Albuquerque. So these programs run every 2 weeks, and we have a fellow and a facilitator, and we really encourage all of you to be very interactive and to put your questions in the chat so we can actually really gain from this and have insights into where you're struggling and where you want to have some more information. So very importantly, welcome to everyone, and we hope this is going to be a very interactive session. Our presenter today is Sandy Mosenye. He's our GI Liver Fellow from Botswana, who's with us in Cape Town. And he's really going to cover a very important topic of fatty liver disease, which really is a rising problem across the world, as you were here. So Sandy, over to you. Sandy, just unmute.
Yeah. Thank you, Prof. Thank you, Prof, for your introduction. Good evening, colleagues. My name is Dr. Sandy Mosenye, as Prof has said. I'm a first-year fellow in hepatology with the University of Cape Town. I'd like to, first of all, take this opportunity to welcome you, just like Prof has done, and to also thank you for giving me this opportunity, this audience, when I'm presenting my title, MAFLD. This is a very interesting topic. It's a broad topic, and I'll try and give a synopsis or summary of what it entails, and I will ask colleagues to go and do further reading on it, because it's a very, very important topic. What you will notice along the presentation is that I will talk about MAFLD, interchanging it with NAFLD. It will be intentionally so because a lot of literature exists when the disease is called NAFLD. And essentially, these are two different terms describing one entity, one disease entity. So don't be worried when I keep on interchanging like that. So this is the outline for my presentation. I'll give an introductory overview. Then I will talk about the epidemiology of NAFLD, definition of terms, pathogenesis of NAFLD, MAFLD, clinical presentation, diagnosis of NAFLD and MAFLD, investigations and management. So by way of introduction, in 1980, Ludwig and his colleagues described a then unnamed disease, which is characterized by a presence of striking fatty changes with evidence of lobular hepatitis, focal necrosis with mixed inflammatory infiltrates, and in most instances, Mallory bodies in moderately obese patients, many of whom had obesity-associated diseases, such as diabetes mellitus and cholelithiasis. These were patients not taking alcohol. So Ludwig and his colleagues named this disease non-alcoholic steatohepatitis. To put things into perspective, the NAFLD is the presence of more than 5% hepatic steatosis without causative factors such as alcohol, certain drugs, and other defined liver disorders. So its histological spectrum is simple steatosis, non-alcoholic steatohepatitis, and advanced fibrosis. Overall, 3 to 5 patients develop NASH, with 1 to 2% developing advanced fibrosis. It is essentially an under-recognized liver manifestation of metabolic syndrome. So despite the devastating impact and the rising prevalence of this disease, the nomenclature and the diagnostic criteria for this disease had not been revised until 2020, when a panel of international experts from 22 countries proposed a new definition for the diagnosis of this disease that is both comprehensive, simple, and is independent of other liver diseases. So they called it MAFLD, that is metabolic dysfunction associated liver disease. So, the proposal to amend the definition, from NAFLD to MAFLD, basically was what I'm talking about. So the definition is hepatic steatosis, looking at either histology, imaging, or biomarkers with one of the following criteria, 3 criteria. So overweight, BMI more than 25 kg per meter squared, obesity, BMI more than or equal to 30 kg per meter squared. And then type 2 diabetes, metabolic risk factors, that is increased waist circumference, hypertension, hypertriglyceridemia, low HDL, prediabetes, insulin resistance, and subclinical inflammatory inflammation with increased CRP. This is based on positive criteria. It's not a diagnosis of exclusion, and it does not exclude alcohol. It can coexist with liver diseases, and the emphasis really is on the role of metabolic syndrome. So reported studies on MAFLD, right, or reported studies on epidemiology of this disease and risk factors are based on the criteria when we are talking about MAFLD. So the prevalence estimates for this MAFLD vary widely depending on the information available on a given population and the diagnostic criteria used to establish the diagnosis. So a lot more, you'll see that there are different ways in which you can actually establish the diagnosis for this, either liver biochemical test levels or imaging study results or liver biopsy findings. So depending on what modality of diagnosis was used, the prevalence were varying. So Yonosi and his colleague in the study titled Global Burden of MAFLD and NASH, Trends, Predictions, and Risk Factors and Prevention, said that there are nearly 1 billion people globally who are affected by MAFLD. Recent systematic review and meta-analysis by Kiarash R. et al. Estimated the overall prevalence of MAFLD worldwide to be 32.4%. That was published in the Lancet Gastroenterology and Hepatology last year in September. And then data on the prevalence of MAFLD in Africa is scarce, but it is estimated to be 13.5% for the general population. This was also seen by Yonosi and his colleagues, and it was also quoted in a study by Professor Wendy, Spearman, and her colleagues in a study published in 2021, December 2021. So looking at this world map, this is basically depicting the different prevalence in the different continents. So the most hard-hit continent is the Middle East, with a high prevalence of 31.8%, followed by the Latin America, like South America, with 30.5%, and then the Asian continent with 27.4%, and this is followed by North America with 24.1%, and then Europe with 23.7%. The least the less affected is Africa with a prevalence of 13.5%. So the low prevalence in Africa is likely to be an underestimate, considering that there is an increasing burden of non-communicable diseases such as diabetes and obesity, which are essentially driven by the challenges in food insecurity, nutritional transition and associated consumption of calorie-dense foods. So in the distant past, a lot of people in Africa were staying in the rural areas, right, in the villages. So they were tilling, they were getting their food from crops that they grow in the fields. They're getting fruits from the trees. You understand? So they were not eating this refined food, like this, McDonald's kind of food that can increase obesity. So now with urbanization, people are actually now eating all this refined calorie-dense food, and they tend to, gain weight. So for us to say that it's actually at 13.5, it's likely to be an underestimate. And the other possibility that, why I'm saying it's possibly an underestimate is that there's not much of research on MAFLD or MAFLD in Africa. So they still big need for us to do a research on this so that we can get a clear clear prevalence in Africa. So most cases of MAFLD are discovered in middle age during the 4th to the 6th decades of life. There is, however, an increasing frequency in children and adolescents in whom the frequency of overweight and obesity has been reported to be 30% of the population. Studies have reported MAFLD to be more common in men than women. But however, there's a later peaking prevalence in women than men, including propensity for more advanced disease in postmenopausal women. This suggests that there's a relationship between sex hormones and menopause and this disease of MAFLD. So I've already sort of tried to explain or to define the two terms. I will still, go ahead and reemphasize the definitions. So I said MAFLD is defined as the presence of more than 5% of hepatic steatosis without causative factors such as alcohol, certain drugs, or other defined liver disorders, right? And you can also say that fatty liver on imaging, biopsy, or serum biomarkers in the absence of other liver diseases such as hepatitis B, hepatitis C, autoimmune hepatitis, and other causes of fatty liver disease such as Wilson's disease, medication, and inherited disorders. And then also in the absence of significant alcohol intake, that is for men, if they take more than 30 grams per day, it's excluded, and then less than 20 grams per day for women. And then MAFLD is metabolic dysfunction associated fatty liver disease. That is fatty liver on imaging, biopsy, or serum biomarkers, plus one of the following, that is type 2 diabetes, overweight, or obesity, and metabolic dysregulation. This metabolic dysregulation, let's try and look at it this way. So if you look at the top there, the pink, you see that hepatic steatosis in adults detected either by imaging or blood biomarkers or scores, or by liver histology. So if you get that, and then patients are overweight or obesity, that is MAFLD. If they have type 2, you get all that thing that is in the pink, and then they have type 2 diabetes mellitus, that is MAFLD. If you get that pink, that part in pink, and then you get a patient who's lean, as defined, or who is lean or normal weight, as defined by BMI less than 25 kg per meter squared in Caucasians, or less than 23 kg per meter squared in Asians, plus 2 of these metabolic risk abnormalities, that is MAFLD. So now, the proposed new name, MAFLD. The Delphi process was followed to change NAFLD to MAFLD, and the following are some of the reasons raised why new name was needed. So the term NAFLD, they say, is diagnosis of exclusion. As you've noticed, we say that you must exclude other liver diseases, and then you must also exclude significant alcohol intake, right? So from patient's perspective, they say the term non-alcoholic fatty liver disease trivializes the problem. The non and the alcoholic part of the definition potentially places the blame on patients and implies that the treatment must lie entirely on the patient's hand. On the other hand, MAFLD is inclusive, meaning it takes into account that you can have concomitant fatty liver disease with other liver diseases. So example, hepatitis B virus infection in patient with fatty liver, or alcohol in patient with fatty liver. And it better reflects the pathogenic basis of the disease and allows a more comprehensive and standardized approach to patient management. So with this new proposed name, a number of societies endorsed the name. So there was a statement by the international experts led by Mohammed Islam, which was released endorsing the new definition and new name. Then Asian Pacific for the study of liver disease, PASL, also endorsed the new definition, and they even came up with a very wonderful guideline, for MAFLD. I will urge colleagues to actually look at this guideline, go and download and look at it. It's well captured if you want to know more about this disease with the definition of MAFLD. And then there was a consensus from the Middle East and North Africa that was also released endorsing the name. And then Latin American Association for the Study of Liver, ALE, also gave that statement of endorsement. So they were happy with the new definition. Then Prof. Spearman and colleagues from Sub-Saharan Africa also gave a position statement on the redefinition of fatty liver disease from NAFLD to MAFLD. They were also endorsing this new proposed name. So, as you know, with colleagues, there's always, differences. There's always, difference in understanding. So some colleagues, it's understandable. Some colleagues, thought that it's premature to change this name from NAFLD to MAFLD, and they sort of brought about some of the implications for why they say it's premature. So, like example, Yonosi and his colleagues actually published this journal or this article, titled "From NAFLD to MAFLD: Implications of a Premature Change in Terminology." So what they say is that they appreciate that there has been some dissatisfaction with the terminology non-alcoholic, which overemphasizes alcohol and underemphasizes the root cause of this liver disease. But they said, although MAFLD reflects the risk factors for this liver disease, this term is still suboptimal. It leaves a great deal of ambiguity. They said changing the terminology without new understanding of the molecular basis of the disease entity, new insights in risk stratification and other important aspects of this liver disease can create unnecessary confusion, which can negatively impact the field. So they recommended the creation of a true international consensus group to include all the relevant scientific liver societies. So AASLD, ESOL, ALE, APASL, and then they also wanted patient advocacy organizations, pharmaceutical industry, regulatory agencies, and policymakers to be involved. So AASLD also, saying that reaching consensus on MAFLD nomenclature, they were also of the view that the process, ensure that the process continues in a collaborative and inclusive manner. Sister societies have to wait, the outcome of multi-stakeholder process before declaring their view or support of any particular nomenclature. So it brought birth to this global MAFLD nomenclature consensus development. So there was a pan-society MAFLD nomenclature consensus process that was started. And in this case, there was a robust Delphi process with over 100 countries. Remember, with the first one, there were 22 countries. So here with over 100 countries represented. And you can see that in this map here, in November 2022, there was a meeting held in Washington where this whole process was discussed, and a lot of countries were represented, including our own South Africa, where we had a representation, and in Egypt. So anyway, that was about MAFLD and the proposal for MAFLD. So now we'll go back to NAFLD and MAFLD, the pathogenesis. So this is a complex schemata of how fatty liver disease develops. It is a multi-hit kind of pathogenesis, and there are a lot of pathways that are involved. So there's the metabolic dysfunction pathway. You look at this part here, that there's insulin resistance there. So once the patient is, they have they're metabolically dysfunction, they will have insulin resistance, leading to increased insulin in the system and increased glucose. This will lead to increased lipogenesis and then increased free fatty acids in the liver. So basically that is hepatic steatosis. But this increased lipogenesis can actually lead to endoplasmic reticulum stress, which if it keeps on going on, will lead to hepatic stellate cell activation. And this will lead to collagen deposition. Collagen deposition in the liver is basically fibrosis, in the liver. So that's one of the pathways in which this can happen. The other way is increased lipogenesis can lead to mitochondrial dysfunction, leading to apoptosis, which can either directly lead to activation of hepatic stellate cell activation, causing what? Collagen deposition, or it can lead to activation of the hepatic Kupffer cells, those are macrophages in the liver, which will lead to increased cytokines, that is transforming growth factor beta and tumor necrosis factor alpha, interleukin-6, which eventually lead to hepatic stellate cell activation, leading to collagen deposition, basically fibrosis. There's also this part of gut microbiota dysbiosis. So it leads to increased production of lipopolysaccharides, which also, there'll be increased, absorption of this lipopolysaccharides, leading to activation of the Kupffer cells, and then eventually leading to hepatic stellate cells, and then fibrosis. The same applies to this part. When there's lots and lots of fat cells in the body, they will lead to increased free fatty acids in the liver. It's quite a complex schemata of how this pathogenesis of NAFLD or MAFLD happens. So this is another pictorial way to describe the multi-hit theory of how a fatty liver disease develops. So you see there that there's overweight or obesity, calorie excess or inactive exercise, leading to adipose tissue, leading to increased cytokines, adipokines, chemokines, and then there's insulin resistance. That's the first hit. So, you know, that insulin resistance will lead to a fat accumulation in the liver, leading to MAFLD. And then genetics also plays a role. If, especially for lean patients, if they have this genetic, those genes, those alleles in their system, it will lead to de novo lipogenesis, leading to what? To MAFLD. The same applies to what I've already talked about: gut microbiota, increased lipopolysaccharides, increased permeability, leading to oxidative stress, inflammation, mitochondrial dysfunction, gut bacterial-derived endotoxin, activation of immune cells, and then we keep on having insulin resistance, chronic inflammation, leading to NASH, and eventually leading to fibrosis and cirrhosis. So this is, you know, the resultant pathology, which is basically a spectrum, the disease spectrum of what MAFLD entails. So we see that there's simple steatosis, which is fat accumulation in the liver. And then we have steatohepatitis, which is development of inflammation in the liver. So you see inflammatory cells starting to come on board. And then fibrosis, where there's now laying, or can you see on the my cursor there, where there's you know, fibrosis developing. And then once this keep on happening, this fibrosis keep on happening, it leads to now cirrhosis. And then, as you know, cirrhosis is a good milieu for development of hepatocellular carcinoma. But as you've had in last week symposium on hepatocellular carcinoma, some patients can actually develop hepatocellular carcinoma directly from, you know, like steatohepatitis, not necessarily having gone through cirrhotic phase. So this slide, I just want to illustrate the worldwide prevalence of different stages of MAFLD. So in terms of steatosis, about 25% of you know, that percentage of the world prevalence accounts for steatosis. NASH is 3 to 5%, and cirrhosis is 1 to 2%. What are the risk factors for MAFLD or MAFLD? So there are major risk factors and common or uncommon risk factors. I've sort of already talked about when I was describing the pathogenesis. So we talked about overweight or obesity. We talked about central obesity. So, you know, some people can be slim, not necessarily like, and then have central obesity, like around the tummy. They're not like globally obese. And then we have type 2 diabetes mellitus. We have dyslipidemia, arterial hypertension, metabolic syndrome, insulin resistant, dietary factors, sedentary lifestyle, sarcopenia. And then the uncommon factors, we have gut microbiota, hyperuricemia, hypothyroidism, obstructive sleep apnea, or sleep syndrome, polycystic ovary syndrome. And then we also talked about genetic variations. So those are some of the genes that have been found that if you have you know, those genes in your system, you are likely to have de novo lipogenesis, eventually developing MAFLD. So now, should the high-risk population be screened for MAFLD? Recommendation is that yes, screening for MAFLD by ultrasonography should be considered in a high-risk population, such as those populations that I mentioned on the left side. You know, patients with obesity or overweight, type 2 diabetes, and metabolic syndrome. And then patients with MAFLD should be assessed for other components of metabolic syndrome and be treated accordingly. So now I'll try to zoom into the risk factors themselves. Metabolic syndrome it's a major risk factor for MAFLD. In fact, MAFLD is the liver manifestation of metabolic syndrome, and it's part of a multi-system disease. It is core to non-communicable diseases, and its pooled prevalence in sub-Saharan Africa ranges from 11.1% to 23.9%. The pathogenesis of MAFLD involves a complex interplay between genetics, epigenetics, that is microbiome, I've already talked about that, environmental triggers such as obesity, type 2 diabetes, being the predominant modulators for MAFLD and NASH. And then obesity. So it is associated with 3.5 times increased risk of MAFLD. And then, as I said, visceral adiposity is its surrogate marker, that is waist circumference, is a key risk factor for many complications of metabolic syndrome. And it has a stronger association with MAFLD than does BMI alone, predisposing to a greater risk of NASH or fibrosis. So increased visceral adiposity is a risk factor in a development of MAFLD in lean individuals. So you see that some people may be lean with a BMI of less than 25, and then in Asian population with a BMI of less than 23 kg per meters squared. But if they have this allele, this gene in them, they are more likely to develop MAFLD. And then type 2 diabetes. The relationship between MAFLD and type 2 diabetes is bidirectional, meaning you have diabetes, you can develop NAFLD, and then you have NAFLD, you can develop type 2 diabetes. And the global prevalence of NAFLD in patients with type 2 diabetes is based on ultrasound or proton magnetic resonance spectrometry. Is very high at 55.48%. NAFLD is associated with a roughly 2.2-fold increased risk of incident diabetes with risk paralleling the underlying NAFLD severity. And then the global prevalence of NASH among individuals with type 2 diabetes is 37.3%, with advanced fibrosis occurring at 17.0% of patients with NAFLD and type 2 diabetes. Dyslipidemia. Ratios of high total cholesterol to HDL cholesterol and high triglycerides to HDL cholesterol are associated with increased risk of advanced NAFLD. The global pooled dyslipidemia prevalence estimates are 69.2% in patients with NAFLD and 72.1% in patients with NASH. And then the pooled overall prevalence estimate for hypertriglyceridemia are 40.7% in patients with NAFLD and 83.3% in patients with NASH. I mentioned polycystic ovary syndrome. This one is basically through the insulin resistance brought by polycystic ovarian syndrome. And metabolic syndrome affects about 10% of the female population. So this is a high-risk group for the development of MAFLD and NASH. And then gut microbiome. They say the gastrointestinal tract and the gut microbiome composition play a role in the development of NAFLD, in that clinical studies have shown that NAFLD is associated with dysbiosis, characterized by increased growth of bacteria, such as Enterobacteriaceae and E. coli, and a decrease in Faecalibacteria prausnitzii. Intestinal dysbiosis and microbiome instability influenced by the consumption of saturated fatty acids, fructose and advanced glycated end products contribute to development of liver disease. So I've already talked about the bidirectional relationship between MAFLD and some of the diseases. You can see here that if you have NAFLD, you can develop obesity. If you have NAFLD, you can have high blood pressure. The same applies to dyslipidemia. And there's also that bidirectional, like going backwards. Okay, you can have dyslipidemia and this will predispose you to NAFLD. The same applies to prediabetes and diabetes because of the insulin resistance. And then so with NAFLD, there's increased vasoactive and thrombogenic molecules. Remember, there where I was talking about the Kupffer cells, the macrophages in the liver. If they're activated, there's going to be the production of different cytokines, including this transferrin growth factor beta, which is one of the risk factors for cardiovascular risk factors. Okay. So clinical presentation. Patients with MAFLD can present with extrahepatic manifestations, which include cardiovascular disease, cerebrovascular disease, chronic kidney disease, extrahepatic malignancies, polycystic ovary syndrome, and sleep apnea. And NASH with advanced hepatic fibrosis can rapidly progress to cirrhosis and decompensate with hepatic encephalopathy, ascites, varicose bleeding, and death. And then although liver-related mortality is increased, cardiovascular disease remains the leading cause of death in patients with NAFLD and fibrosis stages F3 and F4. So what basically they're saying is that you get a patient with NAFLD, right? But the main cause of mortality in those patients, it has been found to be more of cardiovascular diseases than the NAFLD itself. And what I can say is that as much as NAFLD can present with these extrahepatic manifestations, it is more likely to be diagnosed incidentally, as different guidelines for management of obesity, for management of diabetes or dyslipidemia or hypertension. They're not really recommending regular screening of this. So we must have to take it upon ourselves that once we see these patients who are at risk, at high risk factors for MAFLD, we have to screen them. So so high risk population from MAFLD, related fibrosis. Those are those obese patients, type 2 diabetes, metabolic dysfunction, right? And then hepatic steatosis, once it's detected on them, it will lead, you will be able to diagnose the MAFLD. Now, different ways of diagnosing MAFLD. You can diagnose it using ultrasound, or let me just say imaging. So imaging, one of them example is ultrasound. You see here that the liver there is hyperechoic. Usually we compare the liver with the kidney or the spleen, right? You see that it's more whitish. It's hyperechoic as compared to the kidney and the spleen. So this is a fatty liver. And then the non-invasive methods of predicting MAFLD. So the fatty liver index is one of them, and it's calculated using the BMI, waist circumference, triglycerides, and gamma, glutamyl transferase, the GGT. And if you check in your phones, you'll see that there's actually an app, where you can easily just calculate that. And for interpretation wise, fatty liver index below 30 means that fatty liver is ruled out. If it's between 30 and 60, it's inconclusive. If it's above, or if it's 60 and above, means the patient has a fatty liver. And then I mentioned that patient can also be done histology, right? So we can see in this case here, example, this is a histological feature of isolated fatty liver. The characteristic features of diffuse macrovesicular steatosis without significant necroinflammation. So you can see all these macrovesicles, these white, those are fat vesicles, that are contained in the liver. In this case, there's not yet fibrosis, as you've seen in the previous slides where there's fibrosis. So assessment for fibrosis. Once you've diagnosed MAFLD, there's risk for advanced fibrosis. So you have to now assess for fibrosis, and there are different modalities or different ways of assessing for fibrosis. So you can use either hepatic fibrosis biomarkers. I'll talk more about them, and then you can use liver stiffness assessment measures. So if you get patients falling into the low risk, you have to repeat this non-invasive test in intervals of 2 to 3 years. If they are intermediate or high risk, then you have to refer them to specialist referral center, where the further tests will be done. If they are confirmed to be cirrhosis, then cirrhosis will be managed with varicose screening and treatment, and then hepatocellular carcinoma surveillance, and then if there is feasibility for liver transplant, once they are indicated for liver transplant, they can be transplanted. If they're still not yet in the cirrhotic phase, then you can go for the therapeutic options, which are different, quite a number of them. So there's the lifestyle modification, there's metabolic risk management, there are those drugs, pioglitazone and vitamin E. I'll talk more about that when I'm talking about the management. And then you have to now consider repeat evaluation every 1 year, consider eligibility for clinical trials, and then also even surgery, like bariatric surgery for these patients. So these are the different modalities or ways in which you can assess for liver fibrosis. So there's the hepatic fibrosis biomarkers, the FIB4, the non-alcoholic fatty liver fibrosis score, the APRI score, which is the AST to platelet ratio index, the enhanced liver fibrosis, the ADAPT, the fibro test. For me to try and explain all this, it will take a long time. It will need another session. And then liver stiffness assessment, the FibroScan, vibration control transit elastography, the MRE, magnetic resonant elastography, and then all those other ones, supersonic shear imaging, acoustic radiation force impulse. These are different measures in which you can measure fibrosis. Basically, what I'm trying to overemphasize is that once patients are diagnosed with MAFLD, then the next step is to assess whether they are at increased risk of fibrosis. And then you can also go further step and risk stratify them. so that you can stratify them into low risk, intermediate risk, or high risk. So if you're using the APRI, if they're less than 0.5, it's low risk. In between, that's intermediate, and more than 1.5, that's a high risk. FIB4, 1.3, 2.67, middle, intermediate. On the right is high risk, left is low risk. And then, the same applies to NFS. So the reason for this non-invasive test, the reason why they're needed is, one, to establish the diagnosis of MAFLD, and then two, to assess for disease severity. So once you do those tests, you'll be able to risk stratify to see whether they're fibrotic, and then what level of fibrosis they have. And then also monitor disease progression and treatment. So once now you've diagnosed them, you've risk stratified them, and then you start the treatment. And then you have to keep on checking them with those modalities for fibrosis to check whether are they improving, or are they actually worsening, or that kind of thing. That's what you need this test for. Then among the various histological features of MAFLD, the degree of liver fibrosis has the strongest correlation with future liver-related morbidity and mortality. Therefore, non-invasive tests of fibrosis are very important. So you can group them into simple fibrosis scores, specific fibrosis biomarkers, and imaging biomarkers. Okay, so we've already talked about them. I just wanted to bring this slide here, just to reflect that there are a number of causes of fatty liver disease. Okay, so it's not only MAFLD that causes fatty liver. There are a lot more causes that can cause fatty liver disease. Example, obviously we've already talked about metabolic syndrome, which is the causes being those ones. Metabolic associated fatty liver disease. And then we have alcohol associated fatty liver disease. So if you take significant alcohol, more than 25 standard units per week in men, and more than 14 standard drinks per week in women, over a 2-year period, you can actually develop alcohol associated fatty liver disease. And then if you take 5 standard drinks in men, or 4 standard drinks in over a 2-hour period, that's binge drinking, then you can easily develop fatty liver. And then the lifetime alcohol intake of more than 100 kg can also lead you to develop alcoholic associated fatty liver disease. So the other causes for fatty liver, we have long-term use of statogenic medications such as corticosteroids, valproic acid, tamoxifen, methotrexate, amiodarone, and exposure to some of the chemicals, hepatitis B, genotype 3 infection, Wilson's disease, all those different diseases, they can actually cause fatty liver. That is why, that new term was proposed, because you want to be able to say this disease can actually exist in their own, or as an individual entity, or they can exist, together. So you can have somebody with fatty liver, secondary to metabolic fatty liver disease, and then you can have somebody with fatty liver with alcohol. These people can coexist, or this disease can coexist, and the problem can be doubled. For diagnosis of MAFLD in the setting of other liver diseases, basically that's what I was saying, is that since MAFLD is no longer a diagnosis of exclusion and is based on the presence of metabolic dysfunction, it is now possible to diagnose its coexistence with other liver diseases such as alcoholic liver disease, chronic hepatitis B virus infection, chronic hepatitis C virus infection, primary biliary cholangitis, to mention a few. Then individuals with concomitant MAFLD and other liver diseases are likely to have different natural history and response to therapy than those with liver disease of a single etiology. MAFLD may accelerate the progression of liver disease in patients with alcoholic liver disease and chronic hepatitis B, and synergistically induce liver cirrhosis or even hepatocellular carcinoma development. So, it's self-explanatory. Somebody with alcohol who's taking lots of alcohol and then has alcoholic fatty liver disease, if they're obese and they have on top MAFLD, it can easily progress faster to cirrhosis, as opposed to if the person was just having one of these diseases. The same applies to chronic hepatitis B. So you have chronic hepatitis B, you're being treated, but if you have superimposed MAFLD, you're more likely to progress further to cirrhosis than somebody with just chronic hepatitis B alone or MAFLD alone. Management of MAFLD, the optimal therapy for MAFLD has not been established. There is, however, a general consensus that treatment efforts should be targeted to patients with steatohepatitis, particularly with fibrosis. And then histologic improvement in steatosis, inflammation, and fibrosis is the ultimate goal of treatment. Treatment strategies are grouped into lifestyle modification, surgical interventions for weight loss, and pharmacotherapy. So there's this table that I wanted to bring to attention to colleagues. So we have dietary advice, we have exercise advice, we have bariatric surgery, we have pharmacotherapy, the current, and then we have pharmacotherapy, the future. I'll try and touch more on this in some slides to come. So lifestyle modification is often divided into reduction in calories with a goal of weight loss, macronutrient modification, and physical activity, including aerobic and resistant activity. So nutritional counseling and caloric restriction leading to weight loss have been shown to improve hepatic histology in several randomized controlled trials. And then they say bariatric surgery leads to substantial weight loss that results in improved metabolic parameters and hepatic histology in patients with MAFLD, according to numerous large retrospective and prospective cohort studies. So pharmacotherapy, weight loss medications, insulin sensitizers, antioxidants, and cytoprotective or antifibrotic agents, and then liver transplantation. For the patient, liver transplantation for the patient where they've already gone to cirrhosis and there is need for transplant. So lifestyle changes, dietary intervention, weight loss, I've already talked about this. Exercise improves cardiovascular comorbidities, insulin resistance, and hepatic triglyceride content. The general consensus is that exercise should be prescribed for 150 to 200 minutes per week in 3 to 5 sessions of moderate intensity aerobic and resistant exercise. I've talked about that. A systematic review showed that resistant exercise improved MAFLD with lower energy consumption. Vitamin E. Vitamin E is an antioxidant that has been extensively studied for MAFLD. The landmark PVEN study showed that vitamin E reduced inflammation and steatosis, but not fibrosis in patients with NASH without cirrhosis or diabetes. So it reduces inflammation and steatosis. So for patients who are still at the early phase, remember in the spectrum, we have steatosis and then inflammation and then fibrosis and then cirrhosis and then eventually hepatocellular carcinoma. So if they're still at the early stage of steatosis and inflammation, you can actually give them vitamin E, which will reduce progression, or it can help it. This is the study there, glitazone, vitamin E, and possible for non-alcoholic steatohepatitis. Then a 2021 systemic review and meta-analysis of 8 studies concluded that vitamin E significantly reduced ALT and AST and improved liver pathology in all histological parameters, as well as lowering LDL cholesterol, fasting blood glucose, and serum leptin values. Other part is that you have to manage the comorbidities. Apart from all those different things so I talked about lifestyle modifications, I talked about some pharmacotherapy like vitamin E. So you have to also now manage the comorbidities, which are risk factors. So management of type 2 diabetes, management of hypertension, management of dyslipidemia, management of obesity, which are the major risk factors and prognostic factors in MAFLD, is very important. So type 2 diabetes, appropriate glycemic control is associated with a reduction in steatosis, a decrease in serum aminotransferases, and improvement of liver inflammation and fibrosis. So specific anti-diabetic drugs might have potential effectiveness in MAFLD beyond the glycemic control. Example, metformin, while it's very good at improving HbA1c, it also has some modest weight loss benefits. And then thiazolidinones, including rosiglitazone and pioglitazone, they have been extensively studied for the treatment of NASH. And in a meta-analysis of 8 randomized controlled trials, use of pioglitazone improved advanced fibrosis in NASH, including in individuals without diabetes. However, this These drugs cause weight gain sometimes, and then they cause edema, osteoporosis, and bone fractures, and especially in postmenopausal women. So additionally, these medications have been associated with an increased risk of cardiovascular events and possibly bladder cancer. So, you know, you have to use them with caution. Liraglutide, a GLP-1 agonist, has shown significant improvement in glycemic control and a reduction in cardiovascular events and deaths in people with diabetes. And then it was associated with a significant improvement in NASH histology, ALT improvement and weight loss in a study by Armstrong. And then semaglutide, weight loss improvement in NASH histology, no improvement in fibrosis. This was in one of the articles in New England Journal. Hypertension, the major risk factor promoting the development of MAFLD, and occasionally independent of other risk factors. Remember, what I said is that patients with MAFLD, they tend to, you know, mortality in patients with MAFLD is more, you know, due to cardiovascular risk factors. So if you have somebody with MAFLD and they have hypertension, you have to really, really control the hypertension, because it's one of the, hypertension itself alone is one of the risk factors for coronary vascular disease or cardiovascular diseases. So if they're now coming together like that, you have to really control the hypertension. Dyslipidemia, most studies have shown that efficacy of lipid-lowering drugs in patients with MAFLD and NASH. These drugs include statins, fibrates, and ezetimibe. Statins are the most widely used and have shown efficacy in reducing cardiovascular mortality in patients with coronary artery disease and type 2 diabetes. Statins are safe and effective in patients with MAFLD and NASH and have no excess hepatotoxicity. But you know, so that effect is mostly on the prevention of the cardiovascular part. They don't necessarily show any improvement in the MAFLD, like in the NASH or in the fibrosis. Obesity. Bariatric surgery is an effective treatment for obesity with regard to MAFLD and NASH. It achieves histological resolution of NASH through both weight loss independent and weight loss independent mechanisms, dependent and independent mechanisms. So the complications for MAFLD or MAFLD, we have MAFLD-related cirrhosis with complications and such as portal hypertension, and then, as I say, you know, we have hepatocellular carcinoma, which can occur as a complication. So, what is my take-home message? Metabolic dysfunction-associated fatty liver disease is fatty liver on imaging, serum biomarkers, or histology plus either type 2 diabetes, overweight, or obesity, or metabolic dysfunction. Its worldwide prevalence is 32.4%, and the prevalence estimated in Africa is 13.5%. It's commoner in males than females, but we say that there's you know, as the female, you know, ages, they tend to have like increased prevalence there in an advanced age. And then the pathogenesis involves metabolic dysregulation, gut microbiota dysbiosis, inflammation, and subgenetic involvement. And the risk factors, as I've overemphasized, are obesity, overweight, central adiposity type 2 diabetes, metabolic syndrome, arterial hypertension, etc. And the major indicator for morbidity or mortality in MAFLD is fibrosis. And then I said there are non-invasive measures for fibrosis that have been validated in measuring fibrosis. Example, FIB4, NSF, APRI, SSI, FibroScan, and MRE. And MAFLD can lead to cirrhosis and even hepatocellular carcinoma. I will at this stage, I'd like to say thank you for your audience. Thank you for listening to me. I will open to questions, and I hope Prof will help me in terms of questions.
Thanks, Sandy. I mean, that was really an excellent overview of a vast topic that I think all of us need to have an approach to and an understanding, because it really involves, as you see, 33% of the global population. Maybe just stop share, Sandy.
Oh, yeah.
So I think, yeah, really very important to have an overall approach and understanding of MAFLD. I mean, if we just look at the burden of disease in terms of complications and need for liver transplantation. So if we go back sort of 5 years, probably hepatitis C was leading the way in terms of indications for liver transplantation. And then was the introduction of DAA therapies and superb response of SVRs were over 95%. In fact, the need for liver transplantation for for hepatitis C actually has decreased significantly. And so what we see rising now is indications being non-alcoholic fatty liver disease or MAFLD. And importantly, the problem with these patients is, as you've seen from Sandy's talk, they have a number of comorbidities relating to non-communicable diseases, so diabetes, hypertension, renal dysfunction. And one of the interesting components is that they often have quite significant interstitial fibrosis. So when you're assessing these patients, you really need to look at that quite carefully. And that's why it's really important to actually address all those co-factors that are driving the development of fatty liver disease. Sandy really covered very nicely how the terminology of MAFLD came into being. And so what they've looked in, as he mentioned in November of last year at the ASLD, what they look to see is actually, as he mentioned, there's only 22 countries involved, really expanding this across the globe more inclusively. And as mentioned, policymakers, research, patients. And so now the more recent round of Delphi questions is actually covering about 300 countries, so much more inclusive. And probably what's going to come out of that is an overall terminology of fatty liver disease, and then under that sort of subcomponents of metabolic dysfunction associated liver disease, alcohol, then drug-induced, and pediatrics. So sort of we'll have an overarching term named as fatty liver disease, and then those subcomponents. I think that Sandy really showed the importance that, particularly now, we see MAFLD being an important cofactor of other liver diseases. So particularly in our liver clinic, we see a problem in patients with hepatitis B. We are well under control, and you see their transaminases beginning to rise. Their DNA is suppressed, HBV DNA is suppressed, but when you do an ultrasound and then follow that up with a FibroScan, they've got fatty liver disease. So it's a real problem. And then particularly, as you mentioned, the combination of fatty liver disease, metabolic syndrome driven, and alcohol. And the thing about the alcohol is that it really doesn't have to be significant, sort of, 1 to 2 units a day, so really not excessive amount. But that combination is really very problematic in terms of driving the development of cirrhosis. Another important thing before we just get onto those questions is that clinically, they are quite interesting in that when they decompensate and progress and develop cirrhosis, they develop the complications of portal hypertension. So they maintain their synthetic function really quite until very late. So if you'll see that, if you look at that liver biopsy, they have that pericellular fibrosis, so they have compression of the sinusoids. So they develop portal hypertension quite early. And their complications relate to portal hypertension with variceal bleeds and ascites. They tend not to be jaundiced, and they have INRs that are, mainly just marginally above 1.5. So that's quite an important sort of clinical clue, as opposed to somebody with alcohol-related cirrhosis and decompensation, who are almost always jaundiced and much sicker and have deranged INRs. And then, as important to remember that these patients are at risk of HCC even in the absence of cirrhosis. So NASH plus fibrosis, those patients need to be screened for HCC sort of on a 6-monthly basis. And then I think those, the benefits of those non-fibrosis markers is that and particularly what is very easy to implement is the FIB4, which looks at age, ALT, AST, and platelets. And so you can easily in that see whether they are very low risk and can stay in sort of primary health care or non-specialist care. Those that are intermediate between 1.35 and 2.67, those are the ones that you probably have to up-refer, hopefully do a FibroScan, and depending on that, keep them at secondary, tertiary level or refer them back down. And then obviously those more than 2.67 really do need to be in tertiary care. And I think that's quite an important quite an easy way of monitoring, and particularly if you think that most of these patients are going to be managed by general physicians, endocrinologists, diabetologists, lipidologists, rather than necessarily gastroenterologists or hepatologists. So that's just sort of an overview. So if we just look at some of the questions that have come through. So in terms of the therapy for MAFLD, I think what one needs to remember that diet is really the cornerstone, and exercise. And with exercise, you have to combine both cardio and resistance. And with weight reduction, in fact, if you lose 5% of your weight, you have reversal inflammation, and 7% you have reversal of fibrosis. So one can't underestimate the benefits of lifestyle changes. There are no FDA-approved drugs for steatohepatitis, for NASH at this point in time. But if we look at what is probably the most beneficial in terms of those who have underlying diabetes, pioglitazones are certainly being shown to be effective. The SGLT1 really haven't as yet been shown to reverse fibrosis, but they have shown to improve steatosis. But it's probably early days for the SGLT inhibitors. Certainly the GLP-1 antagonists, those have been shown to improve inflammation and also reverse fibrosis, and are associated with quite significant weight loss. But as I say, they haven't as yet been FDA approved for steatohepatitis, but if you've got somebody with poorly controlled diabetes and NASH, that certainly is definitely an agent that you'd be considering for. And then Barbara asked, is vitamin E safe to use in diabetic patients? So initially, the prevalence study raised concerns about vitamin E in diabetics, but subsequent studies have actually shown that you can use it in diabetics, and you can even use it in compensated cirrhotics, but shouldn't use it in decompensated cirrhotics. There is an increased risk of cardiovascular complications and prostate cancer. So vitamin E, I mean, we wouldn't go more than 400 units, but it's certainly something, if you don't have access to the other more expensive agents, is something that you can consider. Just in terms of, I think there's from a question about standard drinks per day per week. Suggestion to adopt a standard international unit such as grams per day per week. It requires a practitioner to know the concentration of each type of beverage, beer, spirits. Yeah, I mean, that's always it. Always the thing is, how do you actually assess the amount of alcohol in a glass of wine or beer, or and so they're actually quite easy. I mean, obviously grams per day, but you're still going to have to work it out per whatever drink you're using. So they're quite interesting. They're quite useful visual aids where it actually shows you 250 mils of beer, 200 mils of alcohol, of wine, exactly how many units that are. And that's probably, when we're engaging with one's patients, that's probably maybe easier to actually, and they can actually point out to you, this is what they're actually taking in. But I agree, whether it's units or grams, it can be quite confusing. But I think that sort of visual aid, because ultimately we want to find out from the patient how much they're taking. And so that's often, we find that quite useful. From Sia, what is the sensitivity and specificity of ultrasound in picking up fatty liver? So that's a very important question, because often patients they complain of right upper quadrant discomfort. And that's one of the interesting things, is that, as you know, in liver disease, pain is really not a feature unless you're stretching that capsule. So patients with non-alcoholic fatty liver disease often have big liver, stretch the capsule. So they often have quite a lot of right upper quadrant discomfort. And they notice they have an alpha phos and gamma GT that is marginally elevated. And then they have an ultrasound, which says there's no steatosis. So remember, the definition is more than 5% of hepatocytes having fatty change, but your ultrasound will only pick up when the steatosis is more than 30%. So it's not a very sensitive. And so if you have access to the FibroScan, which can give you the CAP score, that's a much more sensitive way of actually picking up the steatosis. So in a young individual who's not overweight, you expect that CAP score to be less than 210. Once you're going above 250, almost certainly that individual has steatosis. And once you hit the 300 mark on the FibroScan, that basically increases your risk of steatohepatitis, which progressing to fibrosis and cirrhosis. Then there's a question from Joseph: is it advisable to prescribe liraglutide to patients who are not diabetic and have confirmed steatohepatitis and fibrosis? That hasn't been recommended. It is off-label. So your chances of probably getting permission for that is unlikely. So it really is only registered for diabetics. So I think you might struggle at the cost of it. I mean, we have access to semaglutide here in South Africa. The same thing would apply to it as well. Certainly, I think if you've got somebody who has significant non-alcoholic fatty liver disease associated with steatohepatitis and fibrosis, and they've got the metabolic syndrome, then certainly one could make a good argument to using that. Then from Dominique: what's the effect of bariatric surgery on weight loss and the impact on MAFLD? So that is quite an important question, because MAFLD, bariatric surgery is probably underused, and obviously it needs to be done by a center that's actually has experience in actually managing the comorbidities associated with fatty liver disease, but also the psychosocial, because in fact this can be quite profound psychological impact on suddenly losing a lot of weight. And so they need to actually be assessed quite carefully prior to undergoing bariatric surgery. But also importantly, it's not something that should be done in somebody who's got advanced chronic liver disease with cirrhosis, because with the rapid weight loss, they can actually decompensate. And you can imagine also if they're cirrhotic and they already have portal hypertension, the risk of the surgery can be high. So one really wants to pick up those in terms of individuals with a BMI greater than 30, 35, who have not advanced to the stage that they've got cirrhosis and portal hypertension. And then you need to monitor them quite carefully. It is high-risk surgery with high risk, and obviously you need to assess the cardiovascular risk in terms of undergoing that surgery. But it is probably something that we don't utilize as much. Just our sort of own experience, because one of the problems that we run into in our patients when we transplant for fatty liver disease, so they usually have to get below BMI of 30 before we put them on a transplant list, and they're usually quite motivated to get down to that. But then in this post-transplant and setting the steroids, in fact, they rapidly gain weight, and so they can actually regain the weight that they lost within 6 months following a transplant, which is obviously quite problematic in terms of the long-term effect on your graft, but also the cardiovascular risks associated, particularly as those increase in the setting of long-term steroids and calcineurin inhibitors. And so we've had a few patients that we've referred to bariatric surgery centers. And in fact, just with actually entering a organized program where you actually see the psychologist, the social worker, the dietitian, the biokineticist, in fact, they've managed to lose significant amount of weight without actually even requiring bariatric surgery. So I think, I mean, all of us probably don't give our patients with fatty liver disease a really appropriate service. It really should be a multidisciplinary team. So, you know, sitting in a clinic for hours on end, waiting to be seen really isn't the best way of managing patients. One really should have a multidisciplinary team where you've got the physio, you've got the dietitian, you've got the social worker and psychologist. I mean, that's the way to actually really look at patients. We are reaching the stage where they're actually running into problems. I hope I'm answering the questions that everybody is putting through to me adequately for you. I think there's a question here from Lawrence on obeticholic acid. So there was a great hope about obeticholic acid about sort of 5 years ago. In fact, patients gained weight. They also developed pruritus. So it hasn't really been shown to be any long-term benefit in MAFLD. Sia asks how you would position the medical therapies in the sequence of initiation. So I think the first thing is you've got to look at the comorbidity. So you've got to manage the hypertension, you've got to manage the diabetes, you've got to manage the dyslipidemia. And the important thing is that, you know, many of us were actually relatively hesitant about starting statins in individuals with deranged liver enzymes, but there's no contraindication. The only contraindication probably in some use has decompensated cirrhosis. You should not use a statin. Statin have added benefits, decreasing the risk of HCC, and have been shown from the anti-inflammatory effects to also decrease progression from steatohepatitis to fibrosis. So it's certainly something that should not be withheld. But what we would do is usually start off at half dose and monitor it, and then gradually build up to the full dose over 3 months. So there's never any rush in starting a full dose. You can monitor them and see how they manage it. So in terms of the diabetes, it really depends on how severe the diabetes is, whether you're going to go for an insulin regime initially. I think if there is significant steatohepatitis, then those are the ones that you're going to be wanting to really consider the GLP-1 agonists. Unfortunately, remember those access to those in the state sector is very limited. And that's something that we as a group really need to motivate for, because if you look at although the immediate costs are high, the long-term benefit potentially and improving the comorbidities are significant, but that's something that needs to be addressed at sort of the essential medicine list and level. Yeah, this is very interesting. What is preferred BMI cutoff point for races? So, I mean, if you look at the work across Africa, in fact, we know very little about the gut microbiome. We have almost no studies on underlying genetic propensities. So that's really a significant area that's really open to research. If you look at the increased risk in terms of diabetes and obesity that's rapidly rising across Africa and associated with food insecurity. So there was an interesting study that looked at, I think it was from Joburg Group. So they looked at patients, they looked at Black African females, Indian and white Caucasian females, and showed that it was the visceral fat that actually drove the risk of fatty liver disease. And that was highest in Indian women, followed by white women. But really in terms of the sort of visceral fat, and that was looked at, they did an MRI measurement, that was actually very low in Black African women attending the clinic. So that absolutely is an area that we need to look at. I mean, the other interesting is we know that lean MAFLD tends to be more of a problem in sort of Asia. And those ones, I think what is often underestimated is the role of the metabolic drivers in that. So they're not overweight, but they often have an increased weight circumference, and they do have metabolic risks that drive it. So there's not really so much getting the weight down, but actually addressing those metabolic syndrome. So definitely an important area for research, and particularly I think South Africa, where we have really this sort of a wide range of ethnicities. It actually is, this is a very good country to actually look at that and see what are the driving factors. I think, have I covered everybody's questions? So thanks everybody for all their questions, and really importantly, and I hope Sandy's shown you what a vast topic this is. It's really a topic that can open to much research, which very little has been done in sub-Saharan Africa. And if you look at that map in terms of just changing the name, in fact, prior to October last year, in fact, the only country in Africa that was represented was Egypt. Subsequently, South Africa came on, and we now have another 15 countries from Africa on that Delphi process. So I think people are beginning to realize that Africa isn't just one country, that there are multiple countries within it with different risk factors. So really to thank everybody for coming on. Thanks, Sandy, for an excellent presentation. We'd like to thank the Project ECHO from the University of New Mexico for providing this platform, and ECHO India for their support on this fortnightly basis and helping us to run a very efficient program. And really, once again, thanks you to Karen, who make sure that everybody knows what they're supposed to be doing and is here on time. Our next GECHO clinic is going to be on the 17th of April and is going to be alcohol-related liver disease, and the facilitator is going to be Professor Mark Sondrup, and I need to just check, and the presenter is going to be Barbara Mukumbi. So also will be very important, alcohol-related liver disease. If we look at the prevalence of alcohol-related liver disease also rising rapidly across sub-Saharan Africa. So thank you, everyone. I hope you all learned a lot and enjoyed it, and have a good evening. Thanks.
Thank you. Thank you, Prof.
Thanks, everyone. Bye now.
Bye.